Start
This
recording
conference will now be recorded.
for the nice lady. So what I want to talk about today, and Amy wanted to be here, and just the timing was that she can't be, was to kind of go through more specifics about how we screen for and diagnose depression, right? We have these quality measures that we are needing to be following as far as remission rates and screening rates and all of those things. And so we're having, especially post-pandemic, the holidays, a lot of people coming in with mood things going on who are coming up positive on a PHQ-9, but what's the difference between coming up positive on a screener, someone feeling depressed, someone having depression? We want to sort of talk through that a little bit more because it's a little bit more complex, especially in primary care, and especially because a lot of the things that we see with depression are overlapped with a whole lot of other stuff. So I'm not giving definitive answers here. I could teach a semester course on doing this, but to get some thoughts out and sort of expand how we look at this or how we might conceptualize this, and just sort of make sure we're taking all the parts into our diagnoses that we need to be. So imagine you have a patient. I don't know why this is a Joan to me. And then Joan comes in. She's not sleeping well. She's just really down lately, not doing as much with her friends as she normally does. Family's kind of noticed. Work's really stressful, kind of always gets this way during the holidays. And she comes in and she says, I just feel depressed, right? And that's kind of her reason for her visit, What do we do with that? Like, how do we help? What questions do we need to ask, right? And how do we make sure Joan gets better? One of the first things we want to do is sort of recognize, if we're thinking about just kind of from a mood disorder point of view, most of the basic mood disorders or most of the basic sort of anxiety, depression, that kind of first level stuff, all looks the same at low levels, right? Sleep is disrupted, mood is disrupted, appetite, our basic functioning, how we kind of interact with the world. There's a huge amount of overlay between depression, stress, and anxiety, right? And so it can be really hard when someone comes in with 2 or 3 or 4 of these things to go, okay, well, if they fall under every category, what do I do? Where do I start? Like, which one of these could it maybe be? Is it any of these things, right? And so just to sort of be mindful that a lot of the things that we're going to be looking at, we're really, even though they might be using that word, how do we need to look at this, and how do we need to make sure we're taking kind of all of the possibilities into account? Even if we sort of drill down to just depression, what are these different? How do we differentiate these things, right? We use this word depressed a lot, being depressed, feeling depressed, having depression. Are those different? Why do we call them different things? Do we need to call them different things? What does that mean clinically versus sort of casually? Again, all of these things are going to be important because we use these terms a lot and patients use these terms a lot. And so the goal really here is literally, what does this mean? When a patient says that word, right, they feel depressed or they are depressed or they have a history of depression, what are they telling me, right? What are they meaning when they say that, right? And how do I find out what's going on so I can then figure out kind of what best next steps are? Part of what we want to think about is depression as a symptom versus depression as a disorder, right? So if we think of depression as a symptom of just depressed mood, right? Someone has kind of that low mood, a bit of anhedonia, low motivation, kind of feel to it, right? That one symptom just within kind of mental health diagnoses or psychiatric diagnoses overlays with a whole bunch of stuff that's not just major depressive disorder, right? So again, the idea of this being a symptom that a patient is coming in and saying, I have this symptom, us trying to figure out, okay, and what part of what thing is that symptom, right? So just kind of being mindful. I think it can be very easy to say here depression and go like, oh, then it must be major depression, right? It's the same word. our brain very, very normally does that. It connects to like same word, same thing, right? And just to kind of be mindful that even just within the mental health world, depressed mood as a symptom could be a whole bunch of different stuff, right? And if we go off on that yellow one as being part of another psychiatric disorder, or the blue one part of another medical condition, we got dozens of things that this could overlap with, right? So what if we didn't think of depression as just a disorder, right? What if we didn't think of it as just patient has depression, I'm putting it in the chart as a diagnosis, right? What if we said depression is a symptom, right? Depressed mood as a symptom. Then we can think of that as saying, well, if we think of a symptom, symptoms exist on continuums, right? We can have a little bit, we have like a 1 out of 10, and we can have a 10 out of 10, and we have everything in between, right? So we can, if we think of depression as a mood, as a symptom of some mood thing that's happening for whatever reason, then we can again, okay, tell me more about that, right? Tell me what is that depression like for you? What kind of impact is this having? What kind of symptoms are you having? What is the severity of the symptoms, right? We could think of these as, is this an episode of depression, right? Like kind of an isolated thing that has never happened before, that started and that will end? Are we seeing this as like a chronic thing where there's like kind of always like maybe a low level of kind of low mood that's kind of consistent with them over time? Or are we talking about the level of meeting kind of diagnostic criteria, right? Where we're saying this is kind of a diagnosed psychiatric disorder where the severity, the number and the severity of the symptoms and the impact it's having on their daily life does meet kind of, diagnostic criteria to make that formal diagnosis, right? So if we kind of go through these, again, different ways to sort of look at depression. If we think of this, right, as an episode, all we're really saying with that is that there's the presence of depressed mood, right? It's kind of the main thing, plus some of those other symptoms, right? Sleep disruption, appetite disruption, concentration, kind of psycho retardation. We can say, okay, all of those things are there, right? That there is maybe an episode of depression here. We still need to figure out, though, is this part of something else, right? Is this depression secondary to some other disorder? Is this just a single episode of depression, maybe because of something going on in life? Grief, for instance, grief has all the same diagnostic criteria as depression. We just say in the context of loss, and we call it something different. It's exactly the same thing though, right? So that can, is kind of, I think, the easiest example of, yeah, they meet all the diagnostic criteria for depression, but in the context of where those symptoms come from, we would say, like, we wouldn't pathologize someone and say, like, oh, your mom died, now you have a mental disorder because you're sad. We go, look, of course you're sad. Like, that's the normal reaction, right? So feeling depressed can be totally normal, right? Feeling depressed, like depression, sadness, normal human emotion. We all feel them sometimes. Statistically speaking, 20% of the adult population will have a depressive episode in any given year, right? An episode in and of itself is common, right? Life happens, bodies change, pandemics hit, right? Some of these are very normal things. And when we put them in context, when we put them in the history of the rest of their health and the rest of their functioning, we can say, like, okay, this may be a one-off thing. Let's keep an eye on it. Let's do something about it. But, is this kind of, what end of the spectrum are we thinking that this might fall on? For someone who might have more chronic symptoms of depression, you might start looking at something like dysthymic disorder, kind of recurrent episodes of brief depression, or even kind of those short duration depressive episodes, right? Where someone might have a depressive episode that does meet full criteria, but it's not going on for, months. It might really just be a couple weeks, for whatever reason. You might also see people who don't meet sort of have all 5 check boxes, but might have 2 or 3 that are sort of more moderate to severe. So you're talking about people who are experiencing depression that, again, might not have a depressive episode, but that depressed mood is still impacting their day-to-day life, their relationships, their schooling, their job, whatever that is. And then we can think kind of on the far end which is when we get to where the number of symptoms and the severity of symptoms are having such an impact that we would say, yeah, this isn't sort of normal mood fluctuations. This is where we're getting into outside the kind of normal limits or the normal fluctuations of life. And we would say this is getting where we're starting to look at a mood disorder, right? Does that make sense? Kind of like pulling this apart. Some of this is not pathologizing normal human feelings. I have a lot of conversations with patients where they think because they ever feel depressed or they feel anxious, they have a mental health disorder. And we have to sort of walk that back and go like, no, anxiety is normal, depression is normal, sadness is normal, you should feel those things. This is what we would say kind of a depressive disorder is, and sort of help them understand there's nothing wrong with you, like, let's help you feel better, but you're not, like, nothing's broken. And I feel like that's a conversation I have, I don't know that I'd say frequently, but often enough that it sort of made me think of things a little bit differently, in that people are almost like, if they're anywhere on the spectrum, then they must have a mental health disorder. And I'm like, no, like, normal human emotions exist. It's okay to feel these ways. Sometimes that's perfectly normal. We want you to feel better. We're going to help you feel better. But just like if you get strep throat, you're not dying. Sometimes you get low mood periods. The Brits call it low mood, which I love. So you get periods of low mood for whatever reason, and we'll help make that better. But that can also be just a normal fluctuation of the human experience, right? The other thing we want to be mindful of is the PHQ-9, and I won't get on my soapbox about the PHQ-9 because you've all heard me get on that soapbox. But just remembering that screeners are not diagnostic. Screeners tell us we need to ask more questions, and that's really the only thing that they do, right? That's the only thing they're designed for. That's all they can help us with, right? The PHQ-9 does ask all of those sort of 9 possible criteria for major depressive disorder and the severity of them, so they can definitely help us see if someone is meeting those criteria. However, it doesn't tell us the reason for those symptoms. It doesn't tell us the context of those symptoms. It doesn't tell us other contributory factors to those symptoms. It really just says those symptoms are there, and that's all it tells us, right? So when we're talking about diagnostics, just a reminder, screeners are a tool to tell us when we need to ask more questions. Screeners are not diagnostic tools.
What do you think, Dr. Need, about following the PHQ-9 score when you've started treatment? I was going to get
Thank you, Gabe.
I really like that. I feel like people like to see those things just to the left.
I agree. And so I'm going to go to this. If we think of, and again, the languaging, I also get really again, I don't know what they mean by depression. Even in the literature, people with symptoms of depression, and I'm like, what does that mean, right? Everyone has symptoms of depression. We're talking about people that meet diagnostic criteria for a depressive disorder. The languaging even in the literature is a little bit vague, right? So what I like to do, I think the PHQ-9 is a great tool and it's called the Patient Health Questionnaire. It's a great measure of people's health. It's a terrible measure of depression, of depressive disorders, right? So I think if we think of depression as a symptom, right? Like low mood, depressed mood as a symptom, this is a great way to help make sure people are getting better, right? It absolutely picks up on the presence that something's not well, right? It absolutely picks up that people's functioning isn't good, or their sleep is off, their appetite has changed. And the nice thing about, regardless of the cause of some of these things, whether it's anxiety or stress or depression, the frontline treatment for most of it is behavior and an SSRI. So we can kind of do the same thing, even if we're not exactly sure where these are coming from. But I think we can absolutely use these to make sure people are improving. And I think we should, right? I would just put out there for consideration that we don't want to think of this, again, we can't do this as a screener, but if we don't think of this as the severity of their depressive disorder, and we think of it as the severity of depressed mood, then it's absolutely a great measure to make sure people are getting better.
Yeah, I mean, we've all had those patients that come in very reactive, maybe even a personality disorder like borderline, and they don't even read the questions and they check the 3s on both sides. And that's a good example of they've got a lot going on, but it doesn't mean they have severe major depressive disorder.
Correct. Those, for me, I don't, same thing, like, I don't even look at that. To me, that's someone coming in and saying, I am in distress and I need help. And I go, great, put the thing aside, it's not telling me anything. You've already told me you're in distress, what do we need to do? Right? So that's a perfect example of where a screen is going to come positive. It's absolutely not the thing that it's screening for, but it's giving us great information that the patient is in significant distress, and that's why they're here, and then we can help them. But I still have to go like, and what's going on? Right? Like, it's not all of these things, because if it was all of these things, you'd be a puddle on the floor, right? So tell me more of what's happening, right? So in that sense, it's a really effective screener for like patient need, for patient distress, for emotional dysregulation. Works wonderfully. And so, yeah, like, I'm not saying don't use it.
Yeah.
I'm just saying consider conceptualizing what those numbers mean a little bit differently.
Yeah.
And then people tell you what's going on. With, like, in the last 2 weeks, and they say, oh, but I'm not sleeping because my mother's in the hospital. I'm not eating, my mother's in the hospital.
Exactly. And those are the things that, right, where we start to find out that, oh, okay, the context here then is really what makes the difference. Because if you're telling me those things, then I'm like, oh, okay, well then not sleeping because your mother's in there, your kid's in the hospital, that's the normal response. I'm not I'm not going to pathologize this. And that was one of the things when I was in fellowship as a health psychologist, like I had an attending in oncology that just drilled into us, like, you do not pathologize like normal human responses, right? People get depressed when they have cancer because they fucking have cancer. Like, that's the normal response. Getting anxious because you might die is the normal human response. We don't then put you have an anxiety disorder. The normal response is to be super upset that you might die. And I feel like we need to sort of expand that too, to kind of a lot of these things, which is, if we put these in context, is this the response we would that I would have, or that we would expect a typical person to have? And if yes, then I can say, like, okay, I want to get this number down because the patient's clearly got, like, suffering because of this. And also, I'm not going to pathologize what's going on because it makes sense that they have this, they're having this reaction.
And they want you not to pathologize.
Correct.
Right.
It's because this is
and grief is that exact thing, right? Grief is not a diagnosis. It's all the symptoms of depression, but because we put it in the context of loss, we go, oh yeah, that's what you should feel. Ergo, it's not we're not going to diagnose it. But it's all the exact same symptoms of depression, right? We just don't pathologize it because culturally we expect that that's the normal response.
And this is going to really help to change the narrative when they see that, wow, this is normal. I can express my feelings. I feel safe. And I'm not just going to be diagnosed with something just because I'm having normal human reaction.
I have, I do this a lot in OB. I have a lot of new moms that come in for their like postpartum too, and they're like, I thought this was gonna be great, and I don't know, like, I can't do this in my kid, like, and I thought I would be having it, and I'm like, you're a food machine that doesn't sleep. Feeling crazy right now is exactly where you should be. And they're like, I'm not crazy. I'm like, you're not crazy. You're a mom who's like, body is changing back and who's not sleeping and her whole life is upside down. Like, of course you feel that way. And the relief that comes from that is like palpable. To just normalize, there's nothing wrong with you. Like, that's what happens when you have a baby. So I think there is a huge amount of power, in pathologizing a lot of these things. The same thing, kind of not pathologizing poverty, right? A lot of our patients come from backgrounds where they have food insecurity, they have financial insecurity, like they have all of these things going on. They probably are really stressed out. Their sleep probably does have some level of interference. Like, and again, we can do things to make that better, but in that context, that reaction is probably where most people would be. If I'm living on the street, I'm probably not the nicest person all the time, right? I'm probably not sleeping. I'm probably not taking care of my diabetes in the way that my provider would want me to. That doesn't mean I'm non-compliant. It means I'm living on the street, right? So the context for these things, I think, becomes really important. And we can still use these tools for parts of that to say, and let's make sure, just like we wouldn't go like, oh yeah, you've got a lot going on, we'll just leave your blood pressure at 160 over 105 because your life's tough right now. We're going to help make the blood pressure better, right? We can help make people in the best we can, help people to emotionally feel better while also recognizing the context is a big part of it, right? And you're not in the disordered thing where you're having a reaction or you're having sort of an experience we don't expect, right? We're going like, no, that makes a lot of sense. The level of, suffering or struggling you're at for where you are makes sense. Let's help us make that better. But this is kind of the response we would expect from someone in that situation. Assessing for major depression, this seems like a lot, but it's the same stuff. It's the same way that we assess for every other medical condition. If you're going to get an HPI, you're going to get a history of that illness or any related illnesses. You're going to run labs. You're going to get a social history. You're going to do a review of systems. You're going to look at meds. You're going to do a physical. Mostly for the medical providers. I think a lot of times they're like, I don't know what to do. And I'm like, you do know what to do. Like the nurse, I've had this conversation with the nurses in the MA. So like, what do I do? I'm like, you do the exact same thing you do with everything else. You get a history. What are the symptoms? How long has it been going on? What makes it better? What makes it worse? Have you ever been in treatment for it before? Were you ever diagnosed with something? Yes, that's the same questions, right? The only thing that might be a little bit different would be kind of the labs that you would run, kind of things that might be a little bit more specific, again, to depressed mood that we would want to look at from a biochemical level, just because these can be things that have a very direct effect on people's mood. So we're just kind of going to check. You can throw vitamin D in there as well, probably. But again, part of what we're doing is ruling out that there isn't some other thing going on that's causing that depressed mood, so that we can make sure that we're treating the thing that we think we're treating. So diagnostic criteria for major depressive disorder. Again, these are all of the questions that are on the PHQ-9. The difference is, or not the difference, but the main thing here is that they have to have 5 or more of these most of the day, nearly every day for a 2-week period, right? The scoring for the PHQ-9 and some of the things says, well, if it's 2s, then you can count that as a positive one. I'm a little more conservative in my diagnosing. 3 days a week versus 7 days a week is pretty different to me. So I won't say I had to diagnose, but I will say the DSM does say most of the day, every day for 2 weeks. And that can be important. I've had patients that said, oh, my depression came back really bad. I'm like, oh, tell me about it. They're like, yeah, like Monday, it just was so bad, and I took a nap and I felt a lot better. I think you were tired. Like, so like, again, sometimes people say like, yeah, I've been feeling depressed every day for the past month. Tell me more about that. Well, by the end of the day, I just feel really down and I just feel really tired and worn out and I'm kind of grumpy. And it's like, okay, but the rest of the day you were fine? Okay, let's talk more about that, right? Maybe this is a sleep thing. Maybe this is an energy thing. Maybe this is a stress thing. So again, we just want to be mindful that patients use these words in ways that we might not use them clinically. And so just being sure that what the patient's telling us is what we think we're hearing, right? And just getting more of that, a bit more of that detail. Because we, if you really look at these, the all day, every day for 2 weeks, to feel 5 of these all day, every day for 2 weeks, that's a pretty high bar. So again, why I get a little like, don't throw these diagnoses around. This is pretty sick. Like if someone really does feel 5 of, at least 5 of these, right? Like so major, could be 7, 8 of them. You're talking some pretty significant levels of dysfunction, suffering, quite frankly. Also to be mindful that those first 2, the orange ones, are the only 2 that are unique to depression, right? All of the other ones we'll find in other disorders, medical and psychiatric. So just that's why when we do the PHQ-2, that's why it asks those 2 questions as a depression screener, because those are the only 2 things that are unique to depression, right? So just to be mindful, someone could have 5 of these, but if it's not A or B, if it's like C, D, E, F, G, and H, then it's not depression because they don't have one of those first 2. They have to have one of the first 2 for it to be considered depression. The other diagnostic criteria would be that not only do they have those symptoms, all day, every day for 2 weeks, at least 5 of those all day, every day for 2 weeks, but that it's also causing significant impairment in their day-to-day functioning in different spheres of life, work, home, school. It has to be that we can't attribute it to any other substance or medical disorder. So, if someone's using heroin, they're probably going to pop positive PHQ-9. Doesn't mean they have depression. They're using heroin. Pregnancy, same thing. There's a reason we don't use the PHQ-9 with pregnant women. It would come up positive all the time, right? We have a whole different screener that we use. So again, just being mindful. That part of diagnosing this is saying that we don't think it's caused by something else. This isn't secondary to some other thing that's going on. Also, again, that we can't explain the symptoms by some other psychiatric disorder. So that could be things like bereavement. That could be things like a depressive phase of bipolar disorder. It could be personality disorders, even adjustment disorder with depressed mood, dysthymia, those sorts of things. Kind of that we've ruled those things out. And that there's no history of a manic or hypomanic episode. So again, this is just kind of checking in to make sure they might meet all these criteria, but to make sure this is unipolar depression versus bipolar depression. If we're looking at, if we've kind of drilled down and go, okay, we definitely think this is major depressive disorder, then just kind of a quick reference for the coding of mild, moderate, and severe. Mild being 5 to 6 of those symptoms all day, every day for 2 weeks. Moderate being 7 to 8, and 9 being, or severe being, 7 to 9, but with more severe functional impact. Whether this is a single episode or recurrent, meaning that they've had a history of similar episodes before, not just low mood, but they've had full-on depressive episodes in the past. So this is also, again, really important, partially for patient care, to know whether this might be an isolated incident versus this is something that might be more chronic, that we would want to be mindful of as far as, screening maybe a little bit more closely, following up with patients, putting them on a prophylactic SSRI even perhaps, to know whether this has sort of been an ongoing thing or a one-off.
Hi.
Hi.
What is your meeting?
I'm talking about diagnosing depression.
Oh. Okay.
You're welcome to sit in if you want.
I'm looking for the money people. I don't know where they are. They're in the break room. Really? Because all
The mutual,
Yeah.
the mutual.
all the
Oh, the mutual
competition
HR.
people.
The HR
Yeah.
game room, yeah.
Okay.
Yeah, so we've got the severity, you've got if it has psychotic features, has its own thing, again, which is different than having a psychotic disorder with depressed mood as a symptom. Whether it's in partial or full remission, which is they met criteria and now they don't anymore, but they might not have 0 symptoms, they might still have some. All of the old coding for the 0.9s, so for depression, for instance, unspecified depression at 32.9, any of those are no longer billable. Anything that's a 0.9, as of 2 years ago.
Yeah.
So
Deal with that too.
yeah. So sometimes the EMR, and again, EMRs are designed by engineers and not by clinicians. When the PHQ-9 is positive and it has that blue button that pops up to add depression or major depression, or whatever it is that pops up, a lot of times it'll pop up when, I don't like that it does that, because again, we're not talking about depression necessarily, just because that's positive, but that's also a non-billable code. So that they have not updated. So we need to be, the payers require us to be more specific than using kind of that generic code, kind of. There is also a code for positive depression screening. And actually in our EMR, that Z13.89 will come up for positive PHQ-9 and negative PHQ-9. So that can be sort of useful if we don't know what the diagnosis is necessarily, or we're not necessarily giving the patient a diagnosis, but they still came up positive on the screen. Or if we're giving the screen and it's negative, we can add it to their problem list as a way to track that it was given, the same way we put in screen for hyperlipidemia, screen for diabetes, right? We have those sort of Z codes that just show that we've screened. So we can also use that as a way to kind of track that we're kind of keeping up with things for patients as well. They did add a new code that I actually found out about when I was making this presentation last fall, that is F32.A, which is a billable code for depressed mood, not a depressive disorder. This is a huge change. For us in behavioral health, traditionally, we have not been able to bill for symptoms. We've only been able to bill for disorders, right? So this is actually the first time that we have a code where we can bill for just depressed mood that doesn't necessarily meet diagnostic criteria for a disorder. So I would encourage, if you're not sure about a diagnosis, if you don't want to make a diagnosis, that's fine. If the presence of depressed mood is there and that's what you're treating, we have a code for that now, right? Partially what we used to have to do is we used to have to put in something. And so we would sometimes have to put in like major depressive disorder just because we had to put some sort of billable code down so that we could get paid, right? And so the system was sort of encouraging overdiagnosis, but we actually do have a code now that we can use just for a depressed mood as a symptom. So I would tell your friends about it because I didn't know about it. I had no idea it existed until like 2 days ago. Wow. And I usually keep up on this stuff because I'm, working with Mary Martin on EMR things. So I don't know why that wasn't more widely spread, but there's a code for it now.
No, because emotional stress is no longer billable. I just put in stress.
It's billable as F43.89. They changed the code because they put in a code for bereavement now. It's like F43.81, I think.
Ooh.
So so they added those two. So I can send that. But emotional stress, I think in our EMR it comes up as like other severe stress disorder. I just changed it to emotional stress. Or other severe reaction to stress, it comes up as something.
So you just keep the code and change what it looks like on the phone.
Yeah.
This is a little bit tangential, but what do you do for coding when there's some significant trauma, but you don't necessarily want to print it out every time? I know you can print, take the time to like print out this after visit summary that doesn't have all the diagnoses, just the diagnoses from that day. But I often wonder if it's, I don't want to trigger people. I might know that, it's my patient, I'm not going to print out their summary with all those terrible diagnoses. But if a partner sees them, I want them to know they have this trauma, significant trauma history, say like childhood sexual abuse or rape, things like that. But then, I don't know, I feel like when you're constantly looking at that paper and seeing, like your life's being real hell.
Yeah.
What do you do about that?
That is so true.
So what I do, and I think, again, these are great conversations we can have at a more systemic level. Yeah. I'll put in, because I'm also a data nerd, I'll put in the code for like history of child sexual abuse, for instance, let's say. I'll put that code in, and then I'll change the descriptor to something like history of childhood trauma.
Okay.
So it's indicated there. You could look at the code, the Z code, and see specifically what it is. And I'll usually put something in the comments that says like, history, so you could go and look at it if you needed to know exactly what that meant. But if you're just looking at the problem list, and we don't really use the CVSs, so like I don't know to answer that. But it would, if it did print out, or if they, we're going to get a patient portal with the new EMR where patients will be able to see their problem list. So to me, that's like a way of acknowledging that it's there, alerting my colleagues that it's there, but not putting like the gory details.
Yeah, okay, that's super helpful.
CVS is clinical
visit summary. Yeah.
And we're supposed to give our patients every single visit, and we give them that, so it's like a not negotiable thing.
And I get them all the time, like come back with like all the diagnoses, if they have the portal, they're like, they put me on this, they put me on that, and I'm like, trying to explain to them why the clinical, the insurance, the reimbursement aspect, but it is very triggering, and I hear it a lot. That's a good point.
It's something we've been sort of talking about, and we're going to have a different conversation when we roll out the new EMR, because patients will have access to their notes, their problem list, all of those things. So how we write our notes is going to be really important. How we put things in the problem list is going to be really important. And that's why I think this stuff is also really important, because I've had patients come in and go like, oh, well, I have depression, I can't work anymore. I'm like, you've got a PHQ-9 of 12. Like, what are you talking about? But the stigma of seeing that, like, just shuts them down, right? So I think we're going to have to be a lot more mindful for a number of different reasons, not only what our payers are seeing as far as funding and statistics and UDS and all of that, but we're now going to have a whole new audience that is not going to have the clinical expertise to understand the difference between like obesity and BMI of 35, right? But what does our chart default to?
Is there any way to like separate, like you said, like we can keep the clinical diagnosis that we need to do separate from?
Well, I think on the CVS we can. We don't have it. We don't know what EMR we're using yet. I doubt we'll be able to because it's really the federal law that requires patients to have access to their records. Yeah. So I don't think we'll be able to hide things.
So if they have a diagnosis from somewhere else, say like Dr. Tagabi or whatever, schizophrenia or whatever, who puts like that into like our EMR?
Medical records, if they get the record.
And then they just label it like diagnosed. I mean, it's from this provider.
Yeah.
Usually it's us after we get like the hospital discharge from Molokini.
Yeah.
And we just put it in.
Just copy, right?
Because I've seen where there was a patient who wanted her diagnosis to be taken out.
Right.
So I guess the patient came, saw a provider, told the provider, this is my diagnosis from this previous, and then the provider put it in or something, bipolar. And then I guess when she saw her record,
right.
and I guess she was doing a court case thing, she was like, what's this? Like, I need this to be taken
Oh, it
off.
happens a lot. I hear patients all the time asking me to do that. I'm like, I can't do that. Like, especially with like the obesity part of it. And I'm like, I get that, but it's just like.
I think we need as a clinic. I mean, I changed every obesity to BMI, blah 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 blah, because it's so stigmatized.
I mean,
and it's completely unmotivating. Once someone's close to obese, who wants to work on their weight, right? Like,
but then part of that, and this will be a whole other conversation.
Sorry.
No, it's really relevant because this is sort of the nuts and bolts part of kind of is that sometimes then what happens is we run UDS reports, and if you take out, if the obesity Z code and the BMI Z code are different, and the report is looking for the obesity Z code, now it looks like we're not screening and we're failing our UDS.
That's a big deal.
So that sometimes it's the code is really important because of the reports we have to run, but then it has this label that's really important to the patient that has a total negative impact.
That's right. Because when I was doing the private like years ago and doing the billing, they were very particular about the code and the wording for it.
Yeah.
And it's just ridiculous.
Yeah. So there's like all these systemic forces that sort of are all overlaying, and so that's why these things sometimes get, the specific diagnosis in the chart can get really important for a whole slew of different reasons. So. Other depression-related disorders, again, just things that can have depressed mood as a symptom that we would just want to be mindful of that we're including in our differential diagnoses.
We don't use that substance-induced mood disorder a lot. I don't see that a lot on lists, but we should be.
I mean, if they're actively, using and that's the cause of their, like a lot of people that are actively drunk or using like opioids at a significant level would, but they might also be physiologically depressed. Are they emotionally depressed, right? That's where we kind of get into some of that other stuff. So it can be a hard thing to figure out. And again, we don't have to figure that out in primary care, right? We don't necessarily have to do this. When it starts to get into some of these things, we would want them to get to specialty care and let them make that effort. The people who know more than we do make the diagnosis and the treatment plan and all of that. So we don't necessarily have to figure these things out, but we want to be mindful that these are also things that they could be before we decide what we're going to put in the chart. Right. Again, kind of going back to the PHQ-9, if this is Joan's PHQ-9, right? She has a score of 14 on here. I personally, and again, we're all independent clinicians here, I would look at this and say probably not depression, because why? Quick exercise.
All the every day, all day long.
right?
Yeah.
So in the more conservative scoring, you could say it's not all day, every day.
And not 5.
Like, this is all of us.
And not the first 2.
Oh, the first two,
Not
the first
question.
The first two,
Yeah.
right, the first two are not, correct, right? You could say because the question number 1 is a 2, that some people would say that counts. For me, the fact that the sleep is a 3, I can explain a lot of that other stuff
Correct.
just by the sleep being off. So my first question would be, tell me more about your sleep. How long has that been happening? Is this a new thing? You know, did one predate the other? Because
And then, of course, if 3 is like that, and 4, of course, is like that.
exactly, right. 3 and 4 are going to correlate a lot. 3 and 7, 3 and 8, right? When we're not sleeping, it just affects every other part of our functioning. So, but exactly what Helen said, you know, if those first 2 aren't, or what Gabe said, if those first 2 aren't, in the more conservative diagnosing, if they aren't a 3, then you're not going to get a diagnosis of depression. So that's the thing. And this is where we get a little trouble. The PHQ-9 is not super great in primary care.
False positive.
Yeah.
Oh my God, I'm so guilty of this.
Because, and this has been going on. This number has actually crept up over the past like 15 years. It used to be about like 50%, and then it was like 65, and then like a month ago I was at a conference and we were Googling something. Someone was like, it's up to 77%. What? We're all like Bluetoothing it to each other. Because think of the things that come into primary care, right? Think of those things, right? Poor sleep, poor appetite, low mood, concentration. These things can be explained by 1,000 other things, right? And so again, the PHQ-9 as a screener can be really helpful in figuring out where the patient's struggling. As a screener for major depressive disorder in primary care, it's not super useful.
So it's just what you said it is. It's the patient health questionnaire.
I feel like it's a great patient health questionnaire. I think it's really interesting. When they created the PHQ-9 in the early 2000s, it was funded by Pfizer. It was developed, I think, at the University of Minnesota or Wisconsin or something. But I think it's really interesting they made a screener for depression that doesn't have the word depression in the name of the screener. I just think that's interesting. I'm not making any, I don't know why, but whatever, it is. And so just, again, kind of going back, because I know we're getting to time, but, you know, the PHQ-9, again, can be really useful in primary care in assessing people's health and their health needs. It's just not super useful in assessing for major depressive disorder. So again, just to be mindful in that use as a tool, that the PHQ-9 is really giving us the presence of depressed mood. It's not telling us whether someone does or doesn't have a depressive disorder. So again, that kind of helps us figure out if we're talking about diagnosing major depressive disorder, kind of someone who may feel depressed, we would want to be careful about misdiagnosing, right? Where we're seeing those symptoms, they check all the boxes, but the cause of those symptoms is not necessarily the thing that we're attributing it to, right? So kind of like Gabe said, someone who's using a lot of substances may have all of those symptoms, not because they have a mood disorder, but because they're using a lot of downers, right? And so physiologically, they're experiencing those symptoms because of the substances that they're using, right?
Like alcohol.
Alcohol, yeah, exactly, yeah, great example. So the diagnosis, you know, diagnosing someone with depression for those things would be a misdiagnosis. The symptoms are there, but we're attributing them to the wrong thing. This is a little bit different than overdiagnosis, where we see those symptoms and they might kind of be for the reasons that we think they are, but we start to a little bit inflate the reason or the label that we put on those symptoms. So like the example that they gave was pre-diabetes, right? Where we sort of get into this realm where there is no such thing as pre-diabetes, but we start sort of diagnosing something called pre-diabetes because they have a higher A1C than we want. Their blood glucose is over 100 pretty consistently, but they don't meet diagnostic criteria for diabetes yet. But we started medicalizing sort of this in-between space that we now are calling pre-diabetes, even though that's not really a thing. So we just want to be mindful kind of the labels that we're using of, some of these things really are, they either do meet diagnostic criteria or they don't meet diagnostic criteria. And if we're gonna say they're approaching meeting diagnostic criteria, how do we record that, right? What do we put that down as? How do we talk about that? But how do we make sure we're not diagnosing something someone does not have, right? Maybe they don't yet have it, right? But someone who's pre-diabetic does not have diabetes, right? So we just want to be kind of mindful in these middle spaces, how we're writing down things, how we're recording things. And then on the end, we would have diagnosis, which is where someone meets the criteria, all the criteria for the reasons that we think they do, and we can say this is an accurate diagnosis of having, in this case, having a depressive disorder. Again, just the idea that diagnosing depression in primary care is really difficult because so many of those symptoms overlay with other things. These are words that we use clinically and non-clinically, so we can get kind of really iffy on some of the wording. When patients tell us something, we need to be mindful, what are they really telling us versus what do we think they're telling us? And just, again, knowing we don't have to diagnose mood disorders in primary care to be able to help our patients. So if this is something we feel comfortable doing or you don't feel comfortable doing, you don't have to do it. And we can still do a lot to help our patients feel better. Part of what happens with that as well, and I say this with love as someone who's married to a physician, is depression is really different than most other medical things in the way we conceptualize it and the way that we look at it. Part of that is depression is what we call a disorder of rule out, which essentially means we have these symptoms and we've ruled out every other cause for them, and therefore we can say this is probably major depressive disorder, right? We can't come up with a physiological reason for it. We can't come up with a contextual reason for it. We can't come up with another diagnosis that is causing it. So since we've reasonably ruled out everything else, we would say this is probably a mood disorder, right? We don't have labs that we can run to confirm. We don't have any imaging we can do. So having to diagnose in this way is really different than most other things like hypertension, diabetes, cancer, where we've got imaging, we've got labs, we've got numbers that show us they're above a number, ergo they have this thing. Depression is very different in that way. And a lot of mood disorders are very different in that way. The other reason is and Gabe is the person that's here, of course, this is like the exception as a family medicine doc, but like most of our providers here are internal medicine. Internal medicine does not require a psychiatry residency or a psychiatry rotation in their residencies.
So, I think in family medicine we did 1 month. Yeah,
which is more than a lot of people have.
Yeah, but not that much.
and Jamie kind of pointed out some stuff when I was talking to her before. Not only that, but for a lot of physicians, they're doing it inpatient in the hospital where you're seeing like the sickest of the sickest who already have a diagnosis or already on treatment. You're not doing it for a long time, right? So you're not seeing what presents in primary care. You're seeing what's in like an inpatient psychiatric unit, which is totally different than what's walking in our doors at Malama, So a lot of our providers maybe did a psychiatry clerkship 25 years ago, and that's the extent of their training, Amy told me when she was in nurse practitioner school, they never taught her how to diagnose. She had to look up the DSM criteria when she started working here. So a lot of the providers, and again, I say this with love, we're asking them to do things they have no training in how to do, right? So can we be super surprised then that we're not fairly accurate as a system at identifying these things? Not really, like kind of it makes sense, makes sense in that way.
When we do a warm handoff and we have major depression on the problem list and you guys are like, nah, this is an adjustment disorder or this is due to substance, we just give us that feedback. We can handle it and it's good for us.
No, and that's what I love about kind of the integrated care model is we all get to learn from each other because, I think it does become very much if all you have is a hammer, everything's a nail, right? Yeah. And so if that's what the screener's telling you, and then, if that's what the EMR defaults to, right, when the PHQ-9 pops positive, that little blue box it doesn't come up positive PHQ-9 screen, it comes up major depressive disorder.
But
right?
And then what are you going to do about that?
Right. So the EMR is even encouraging this diagnosis in a lot of ways, right? So there's a lot of factors here. And so I don't want to blame. I think like there's a lot of things we can do as a system to sort of change things and reconsider things, and with the new EMR, kind of look at ways to kind of prevent some of this. But there's a lot of reasons this happens. And so that's kind of my takeaway, right? This isn't anyone's good or bad or right or wrong or a good or bad clinician. This is just, there's a lot of factors going on here that a lot of times we're not even aware of. And that's why this presentation, I wanted to be like, I just want to bring these people things to all of our awareness, so that we just know all these factors are floating out there, and we'll figure out over time what to do about it. But there's just a lot of layers happening, and that's why sometimes this gets really difficult. We also have a lot of cultural or biological reasons that people can have mood disorders or low mood. There's some great studies that are coming out that are looking more specifically at different populations and how they experience depression, or how their depression presents, or why people have certain symptoms that have nothing to do with a mood disorder. This article from the Wall Street Journal earlier this year was talking about that, menopause, and they're finding out that estrogen receptors in the brain interfere with mood. And so as menopause is occurring and those receptors are upregulating and downregulating, women's mood tends to get really off. And so they go to their provider and they're like, my mood's really low, and they put them on an antidepressant, and that doesn't help them because the issue is hormonal, But they said depressed and their PHQ-9 was positive, ergo we'll give them an SSRI, right? And that's not the cause of the thing, and so we're not really giving the treatment that actually helps, right? Because we're getting caught up in the words. The other reason is, culturally, what does it mean to be crazy? What does it mean to be depressed, right? What's going on TikTok? We get a lot of portrayals of what a depressed person looks like, right? On either extreme, right? Where you have, kind of the movie stuff, Jack Nicholson and One Flew Over the Cuckoo's Nest, all the way to everyone saying, I have depression, I have anxiety, and sort of using those terms kind of to again say like, yeah, but everybody does, right? So being mindful of what's the cultural conversations going on and how are those words getting used. Also remembering, go. The context of things is really important.
I better run, I have a 9.
Okay. I'm recording it, so it's all good.
Okay, thank you.
Yeah.
So good.
I'll send that to Joanne, the rest of you guys can, if you guys have to go. It's no worries. The other thing is to think about, again, going back to the context, right? For COVID, a lot of people felt really low and felt really anxious. That was a normal human response. We were isolated, we were out of our normal routines, we were worried about getting sick. There's things we can do to help make that better, and it's not about saying like, oh, well, that's just what it is. We want to say like, yeah, that's happening, and let's help that feel better, but does that mean it's a disorder? Not really, no. Again, that being in the middle of a global pandemic and being anxious is the normal human response, right? So putting these things in context, again, is just really, really important. Physical diagnoses or medical diagnoses that can mimic symptoms of depression. A lot of these things are things that we may or may not see in primary care. A lot of the endocrine stuff is relatively common. The neuro stuff, we want to be mindful of. A lot of things that we see normally that can look like depression as well. We also have medications that mimic depression. There's been some really good research looking at the number of medications that people take that have depression as a side effect will have an additive effect on specifically their PHQ-9 score, but their sort of subjective reports of depression. So what they found was that the more medications you took that had depression as a side effect, the higher your rates of popping positive on a depression screen were. So for people that were taking no medications, you've got your baseline of about 5%. For people that were taking 3 or more medications that had depression as a side effect, it was 3 times the rate. And that was independent of severity of diagnosis or number of medications in general. So people that were taking 3 blood pressure medications that didn't have depression as a side effect had no increase in depression versus people who were taking 3 medications for blood pressure that did have depression as a side effect, and their scores did go up. So it was very specific to those additive side effects. And then you saw some combinations of those medications that had even more. So the more sort of some of these pain medications that have suppressive effects, gabapentin, cyclobenzaprine, like that prevalence was super high, simply because they're taking medications that are sedative. And so we just, again, want to be mindful. You can see a lot of the things that are on here are those opioid benzo combinations that were causing overdoses, and kind of why Hawaii, as well as other states, passed laws preventing us from prescribing those long term, because they're dangerous in combination. So you can imagine if they're killing people, they're probably mimicking symptoms of depression as well. So those medications, again, a lot of the things that we see in primary care, a lot of the things that are prescribed pretty regularly to a lot of our patients, it doesn't mean we shouldn't prescribe these things. It just means if we're having someone who's reporting some kind of low mood or depressed mood, we would just want to kind of check their med list to make sure or see if there are any of these medications or multiple of these medications that may be in there that could be contributing, and see, is there a way to change the medication they're on? Is this just a side effect we're going to have to learn to manage? Kind of what is it? But again, that we're not saying, oh, it must be depression, and throwing in SSRI on top of all these other medications, when the issue isn't a mood disorder, it's really polypharmacy. This is my sort of flow chart, again, just to kind of help figure out if someone reports that they have depressed mood or low mood. It's just sort of like a way to help figure out what that diagnosis might be. It also just shows a little bit of the complexity of working through kind of the different reasons and the different causes of of low mood. So something that can be kind of just helpful in guiding our thinking, but also, again, shows all the different ways that low mood can be a symptom of, multiple other things. So a suggested protocol for depression would be, if you suspect that may be the actual diagnosis, would be kind of a number of screeners. We want to rule out that it's not some other mood disorder that might be causing things. So again, we want to rule out anxiety, we want to rule out trauma, any kind of manic episodes, substance use, just to make sure that isn't the contributory factor. We want to get just our regular, HPI, medical history, social history, all the stuff that we would do normally for any other medical disorder. Have some of our basic labs that we would run, again, just the biggest physiological contributors to low mood. And then a review of systems, review of the chart, make sure there aren't other conditions that may be mimicking depression, any other medications that could be doing that, whether they're illicit or prescribed, or the combination of medications that may be causing that low mood or those symptoms. Just a reminder, we have a lot of other screeners, so if there is something else that you think may be contributing or you want to just rule out, there are a lot of ways to very quickly and very easily see if those may be factors that you can rule in, rule out for making a differential diagnosis. All of the ones that have asterisks next to them are ones that we have in the EMR. So that makes them easy to use, easy to track. So you can always add them into the document on the side by adding them as a form. You can also ask, again, any of us. We can kind of show you how to do that. There's also a screening, what they call the screening gateway in our EMR that has like all of the screeners in one form. So that can also be really helpful if you're trying to see, and it organizes them by like depression, anxiety, substance.
We get referrals for like ADHD, for behavioral health. Is it safe to say folks can do the screening or just send them straight out to psych?
We can do the screening.
I know it's extensive.
Yeah, in the diagnosis part is pretty extensive because you really do, part of the rule out is doing kind of like a proper neuropsych. And I could talk about that too, because depression or like anxiety is going to contribute, trauma is going to contribute, sleep is going to contribute, medicine, like all of the things that interfere with attention and maintaining attention. So a lot of times I feel like if someone comes in thinking they have ADHD, they're going to come up positive on that screen because they're already identified that they have those symptoms. The question is, do they actually have, again, it's the same thing. They have the symptoms. Is the cause actually a neurological disorder, right, ADHD, or is it stress, is it sleep, is it substance use, is it anxiety, is it, something else? So if I a lot of times won't necessarily do the ADHD screen as the first step. I'll usually do like anxiety, trauma, substance use, like those sorts of things, because most of the time that's what ends up popping positive, and then can have the conversation and say like, well, it could be a neurological disorder, but it's more likely to be this thing. Could we talk about addressing your stress and your sleep and your anxiety, and then maybe kind of see if that flattens out some of those symptoms. Same thing, if they've had, a lot of times people that say they have ADHD and have had it since even school, if you ask about childhood stuff, there was all sorts of disruption, there was, a lot of stuff happening in the home at the time. So again, those diagnoses, I think that's a diagnosis that gets thrown around a lot. Bipolar gets thrown around a lot by the ER. I don't think it's the greatest diagnosis. I think they meet they check all the boxes. It must be ADHD, and it's like, well, it could be childhood trauma. I mean, tell me this kid's been in 2 foster care homes and like severe physical abuse. I'm thinking we need to rule those things out before we say he happens to also have a neurological disorder. So, and that's the end of that. So, I'm not sure if anyone is still on. I know people had to go, but if anyone has any questions, I'm happy to answer them now and or later.
Daniel, can you send, that last screen where you said that we had some of the in our EMR, those tests?
Yeah, I'll send this whole presentation out to everybody.
Okay, all right, thank you.
No problem.
Bye,
All
have
right.
a good weekend.
Okay.
Bye.
Bye, guys. Have a good one.
Alrighty.
Go check those houses.
Yeah.